Thank you. I think I've just realised why Tim and JD chose this rather fetching colour of green. It's to keep everyone awake for the rest of the afternoon. So I'm just going to briefly tell you about the patient factors. Can you hear me at the back? Is the mic on? You can. Okay, great. And I'd just like to acknowledge my co-authors Kate O'Connor and Tim Cook for this chapter. Current knowledge of the causative patient factors for awareness under general anaesthesia. A wide variety of patient and organisational factors have been identified as being associated with an increased incidence of AAGA. However, the results are markedly inconsistent, and I would refer you to page 94 of the main report, where there's a table looking at many of the studies and how the factors have been reported in each of these studies. So in NAP5, features of the Class A reports only were compared to the same features in patients undergoing general anaesthesia in the activity survey. And so the rest of the talk is a rather listy format. I'll try and explain what we know currently and what NAP5 has shown. So first of all, gender. Most studies report an increased incidence of awareness in women. Now, of course, if the studies include obstetric anaesthesia, this will be a confounding factor. But even when you remove obstetric anaesthesia from these reports, it does appear that there is an increased incidence. And there does seem to be some evidence in the literature that women appear to recover more quickly from general anaesthesia than men. And I'll avoid making any sexist comment about that. Closed claim analysis from the UK and USA also demonstrates that a higher number of claims come from women, and again I'll avoid making any other comment about that. So what does NAP5 show? Well, NAP5 definitely shows a preponderance towards women. Women seem to report suffer a higher incidence of awareness under general anaesthesia. What about age? Now, we know that age affects anaesthetic sensitivity and MAC of volatile agents, but there are, again, conflicting reports on the effect of age on the risk of awareness under general anaesthesia. So what does NAP5 show? Well, again, NAP5 does show that age seems to make a difference, and the risk of awareness seems to be increased for young adults. We've heard about children already today, but it seems to be for young adults specifically, but not for children or older patients. What about obesity? Obesity is associated with an increased body fat content, increased lean body mass, increased blood volume and cardiac output. And all of these reasons and more can affect the pharmacokinetics and dynamics of drugs that we would give our patients to induce and maintain anaesthesia. So what does NAP5 show us? Well, again, patients who are obese, who have elevated BMI, are at greater risk of awareness compared to patients with normal body mass index. Now, what about the difficult airway? Patients in whom airway management is difficult may be vulnerable to awareness for a variety of reasons. It could be due to offset of the induction agent while you're trying to intubate the patient. It could be failure to maintain anaesthesia during attempts at intubation. And even if between your attempts at intubation, you're giving that patient volatile agent with bag mask ventilation, this bag mask ventilation may be inadequate and the patient may actually not get any volatile on board. So for all of these reasons, difficult airways may be associated with an increased incidence of awareness. In addition, we know that obesity is a risk factor for difficult airway management. In NAP5, difficulty with airway management was a factor in 27 of the Class A cases. 23 reports described difficult intubation, 5 reported difficult mask ventilation, and 3 reported difficult supraglottic airway device insertion difficulties. And in 5 cases, there were multiple difficulties, either difficult manual mechanical ventilation and insertion of an airway. And when you combined this with obesity, the problems got worse. And of reports of awareness in obese patients, 31% involved difficult airway management, and 37% of the cases of difficult airway management associated with AAGA were in obese patients. So there's no doubt that difficult airway in association with obesity are risk factors for awareness. What about genetic resistance? Awareness may arise from an intrinsic resistance to anaesthesia, and there's been a number of studies looking at this. A study from 2009 looked at 271 published reports of awareness and reported that 1.6% of patients had described a previous history of awareness. The bag recall study, 11% of patients with definite or possible awareness had had a history of awareness. And most recently, last year, a secondary analysis of almost 27,000 patients in 3 major trials investigating awareness found that 241 patients with a previous history of awareness had a 5-fold greater incidence of repeat awareness. So what does NAP5 tell us? Well, in 13 out of 104 Class A reports in which preventability could be assessed, it was deemed that awareness was unpreventable and anaesthetic conduct was good. In 10 of these cases, the panel considered one possibility was intrinsic anaesthetics insensitivity. 28 Class A patients underwent a subsequent GA, and in 24 where information was available, there was no report of subsequent awareness. What about concomitant drug use and alcohol use? There is a perception exists that concomitant use of certain drugs and alcohol can alter the risk of awareness. However, there is little robust evidence to actually support this. Sedative drugs might alter anaesthetic requirements by pharmacokinetic effects leading to altered drug metabolism. And drug and alcohol use can also alter pharmacodynamic sensitivity to anaesthetic agents, leading to a degree of resistance. Now, in NAP5, a wide variety of drugs and alcohol use was reported in the patients who suffered awareness. However, there wasn't sufficient data in the activity survey to do a direct comparison with. Moving on to organisational factors, what about urgency of surgery? And it does seem that urgency of surgery is a risk factor for awareness. There was a higher incidence of awareness in patients who underwent emergency and immediate procedures as compared to elective procedures. What about the time of day? We hear a lot about timing of your surgery, whether it's day, night, and at the weekends. And again, it does seem, which is consistent with emergency surgery, that there's a preponderance towards evening and nighttime cases. There's greater awareness in patients who undergo surgery in the evening and at night. And just to round off, a couple of case vignettes, which I hope you haven't heard already today, which I think demonstrate the factors that I've described. A middle-aged, very obese patient underwent urgent surgery at night. Introduction was with fentanyl 100 mics, thiopentone 500 and succinylmethonium 100, so reasonable doses, one would imagine. There was unexpected difficulty with intubation, and after repeated intubation attempts, during which no further drug was administered, the case was abandoned and the patient awoken. The patient heard discussion about intubation difficulty, felt instruments in his mouth and was unable to move. A second case, a middle-aged, slim, healthy patient underwent urgent abdominal surgery. There was unexpected difficulty with intubation during a rapid sequence induction undertaken by a trainee anaesthetist, and the patient reported awareness to an anaesthetist at a later procedure saying, "Next time you try to put the tube down, please could you make sure I'm asleep?" I could feel some pressure on my neck, some poking around in my throat, and then something larger coming down. Only thiopentone and succinylmethonium were used at induction. So lastly, to summarise, the factors associated with an increased incidence of awareness include the female gender, age, younger adults but not children, obesity, a previous history of awareness, the time of day of surgery would be evening and night time, emergency surgery, and the seniority of an anaesthetist if it was a junior and a trainee. The analysis provides statistical evidence that the following factors are not risk factors for awareness: ASA, race, and ethnicity. This analysis could not provide evidence one way or another for various factors, including drugs, excess alcohol, preoperative anxiety, and the day of the week. Thank you.